Good afternoon, everyone. Welcome back to Pathagonia. Today I'm going to attempt to dive into the central nervous system tumors section from Kurt's notes. So this PDF is about 35 pages long. We'll see how far we get in each episode, but it is my goal to finally dive into it and get through it. I've kind of been staring at it and been daunted by it for a little while, so I'm just going to dive right in. I am a second year pathology resident. I'm applying for neuropathology fellowship spots at a few different programs around the country. And regardless of whether I get into a spot or not, I want to learn more about neuropathology to become a better pathologist one day. And I think the brain is super interesting, so let's just dive right into it. All right, so in general, about 1% of tumors in adults are brain tumors, and about 25% of malignancies in children are brain tumors, which is only second to leukemia for the pediatric population. There's been a significant increase in the incidence in primary brain tumors in the elderly, and metastases to the brain are far more common than a primary brain tumor. And if you see multiple cerebral tumors, you're going to be thinking metastasis most likely instead of a primary tumor. And one can develop a very good differential diagnosis just by location, age, and imaging when it comes to neuropathology. So I've only done a couple neuropathology tumor boards at my institution, but it's very interesting to hear the radiology side of it and just how critical that is to the management of these patients. So I'm not going to go through, there's a lot of tables and algorithms throughout this document. For the sake of time, it is 35 pages long. I'm not going to read every word, but please just reference it on your own. And just my logic is when I'm going through the specific entities throughout the document, I'm going to hit a lot of the high points as far as where certain tumors are commonly located, etc. But as far as just this table on its own, definitely just reference it back. You can make flashcards out of it or do whatever works best for your learning style. I will go over some common abbreviations just so we kind of get a language for what we're going to be talking about over the next, I don't know, probably a couple hours. So PA stands for pilocytic astrocytoma, PXA, pleomorphic xanthoastrocytoma, DNET, dysembryoplastic neuroepithelial tumor, GBM is glioblastoma multiforme, and AT/RT is atypical teratoid rhabdoid tumor. DMG is diffuse midline glioma, which is H3K27M mutant. SEGA stands for subependymal giant cell astrocytoma. MPE, myxopapillary ependymoma. DIPG, diffuse intrinsic pontine glioma. MPNST, malignant peripheral nerve sheath tumor. SFT, solitary fibrous tumor. And Langerhans cell histiocytosis is LCH. PPTID, pineal parenchymal tumor of intermediate differentiation. And DLGNT, diffuse leptomeningeal glioneuronal tumor. So now that we've got those locked in, we can go ahead and move forward. So some classic locations and correlations to be aware of. So on imaging, common findings on imaging for metastases are going to be, like we said before, multiple lesions, so multiple enhancing or rim enhancing nodules, commonly at the gray-white junction in the cerebrum. For a lymphoma, you're going to see periventricular enhancing lesion. For a GBM or a glioblastoma multiforme, we're going to have rim enhancing butterfly mass. Myxopapillary ependymoma is a filium terminale mass. Meningioma, dural lesion with a dural tail that's enhancing. Pilocytic astrocytoma, circumscribed cystic brain mass in the cerebellum of a child, and then ganglioglioma is a child with epilepsy and a temporal lobe cystic mass. And then some classic clinical associations. So for metastases, some common sites of origin that metastasize to the brain are the lung, breast, and kidney, with a strong prediction, also melanoma and choriocarcinoma. So a quick note on grading. So a grade is part of a continuum and estimates malignancy and aggressiveness. Brain tumors are pathologically graded, but not staged, as they're often not resected en bloc. With increasingly small biopsies, IHC, molecular, and cytogenetics are now critical for diagnosis and grading. Some tumors have inherent grades, while others have criteria for grading, often depending on the mitoses, necrosis, microvascular proliferation, and atypia. So generally speaking, grade 1 is going to be low proliferation potential and possibility of a cure after surgical resection. Grade 2 is usually infiltrative in nature and often recur, despite having low levels of proliferation. Some may progress to higher levels of malignancy, and they often survive over 5 years. Grade 3, clear histologic evidence of malignancy, including nuclear atypia, and sometimes brisk mitotic activity. Patients with these tumors often receive chemotherapy and/or radiation, and often survive 2 to 3 years. Grade 4, cytologically malignant, mitotically active, necrosis-prone neoplasms that are often associated with rapid progression and fatal outcome. This includes GBM with survival of less than 1 year and most embryonal neoplasms, with survival dependent on treatment and can be long. So in general, big picture, lower grade, lower proliferation rate, lower mitotic count, and then the more cytologically pleomorphic and malignant it appears, the more mitoses, typically higher grade, worse prognosis. And that's not unique, that's kind of something that you would expect, right, in pathology in general. More mitoses, more proliferation, things are usually a worse grade. All right, so our first big category, we've got gliomas. So tumors derived from glial cells form gliomas, and glial cells are what support neurons in the central nervous system, including astrocytes, which form the blood-brain barrier, and oligodendrocytes, which coat the axons and form that myelin sheath. So the glial cells are the support crew for the neurons in the central nervous system. And then whenever you get proliferation of those glial cells, you get a glioma of some sort. So in general, the glioma is the most common primary tumors of the central nervous system parenchyma. So for diffuse gliomas or infiltrative gliomas, including astrocytomas, there's going to be widely invasive into the brain parenchyma, often not resectable, and they often naturally progress to higher grade lesions, often resistant to therapy. Other astrocytomas like pilocytic astrocytoma, pleomorphic xanthoastrocytoma, and a SEGA or subependymal giant cell astrocytoma are better circumscribed and have different molecular pathways. And as we already alluded to, and that's the reason in a neuropathology fellowship, it's a 2-year fellowship, and 1 entire year is often devoted to research and the other to practice. But there's a big component of neuropathology that is, you need to be aware of the molecular, right? Because a lot of these tumors are really defined by their molecular pathways. That being said, so we have the diffuse glioma molecular pathways. And again, for the tables, the flowcharts, the algorithms, I'm not going to read everything that is stated, but I think it's good for us to reference it on our own and just come back to it and approach the material in whatever way is best for you to learn. So whether that's come back and make flashcards out of it, write it out until it sticks, or just to go to a question bank and try to answer questions on these topics. But a big picture overview, so we have a pre-neoplastic glial cell, which if it has a 1p19q co-deletion, we associate that often with oligodendroglioma, which is a grade 2. So this is mutant and wild type. So IDH mutant on this side, we'll have diffuse astrocytoma, which are grade 2 or 3, or you can have a diffuse astrocytoma glioblastoma, which is IDH mutant, grade 4. For a glioblastoma multiforme, that's going to be defined by the IDH wild type, and that's a grade 4. Diffuse midline glioma, so the association there to know with diffuse midline glioma is that H3K27 alteration. And yeah, just be sure to reference that on your own. This is modified from a talk by Dr. Perry from UCSF, so good to know for sure. All right, next up, is this tumor glial? As opposed to metastases and other non-glial tumors, glial tumors often have fibrillary processes, often also naked nuclei, best appreciated on cytology, like squash prep. They often have infiltrative growth into the brain parenchyma with intratumoral axons, neurofilament positive, and primarily seen with astrocytomas and oligodendrogliomas. There's secondary structures such as perineuronal satellitosis with subpial density, perivascular collections. Eosinophilic cytoplasm with nuclear hyperchromasia and pleomorphism. And then on IHC, something that can help determine if it's a glial process is if it stains with GFAP and or OLIG2 positivity. Of warning, broad spectrum cytokeratins may stain glial filaments as they are both intermediate filaments. So sometimes it can be tricky to even determine if what you're looking at is a glial process. I mean, especially for me at first, or for anyone that hasn't had the training in it yet, or if you haven't been able to rotate through, neuropathology is tough, in my opinion. So look forward to getting better at it. So are these glial cells neoplastic, or is it a mimic? So you can have something called gliosis, or reactive changes of glial cells in response to injury, which includes both proliferation and hypertrophy. So gliosis can histologically mimic a tumor and pose a diagnostic dilemma, especially intraoperatively. This is particularly troublesome as gliosis can be found adjacent to tumors or as part of reactive processes that can mimic tumors radiographically. Early reactive astrocytosis can lead to hypertrophy with enlarged cytoplasm and processes and open chromatin with prominent nucleoli. So longer-term reactive astrocytosis leads to astrocytes becoming gemistocytic with large amounts of brightly eosinophilic eccentric cytoplasm. Of warning, some tumors can appear gemistocytic as well. And then for chronic reactive astrocytosis, you often see around slow-growing lesions with more fibrillar, with long astrocytic processes and Rosenthal fibers, or pyloid gliosis. So on the left, we have gliosis, and on the right, we have a diffuse astrocytoma. And I guess just to my untrained eye, on the right, it certainly looks more cellular. Then on the left, perhaps has a little bit more solid background on the gliosis, and then diffuse astrocytoma seems to, at least appreciating a lot more nuclei, a lot more cells than in the gliosis image. So for gliosis, you're going to have euchromatic round ovoid nuclei, which makes sense, right? If you're thinking of it as a reactive process, whenever nuclei are reactive in other areas of the body, they're often round or ovoid. However, for a glioma, which is not reactive, it's going to be large, hyperchromatic, irregular to round nuclei. For gliosis, you have evenly spaced astrocytes, abundant eosinophilic cytoplasm, astrocytes with variable atypia, no mitotic activity, and then radially oriented fibrillary processes with other reactive changes. For a glioma, however, you can have clustering of the astrocytes, hypercellular, satellitosis, naked nuclei, uniform atypia, and possible mites. So a lot busier on this side versus the reactive gliosis looks a less worrisome to my eye, at least. All right, next up, moving on, we've got astrocytic tumors. So the classic organization and grading for astrocytic tumors, you have the WHO grades 1 through 4. So WHO grade 1 is a pilocytic astrocytoma with an excellent prognosis. And then the diffuse gliomas make up the WHO grade 2 through 4 tumors, which 2 is diffuse astrocytoma, which histologically has nuclear atypia with a prognosis of 5 or more years. WHO grade 3, anaplastic astrocytoma, is going to have 2 criteria, so it's going to have atypia and mitoses. The prognosis is 2 to 5 years. And then a WHO grade 4 is going to be our GBM, which is going to have atypia and mites plus vascular proliferation and or necrosis, and the prognosis is not as good at 1 year. And just to define, I think we're all familiar with this, but atypia is just going to be variation in nuclear size and shape with hyperchromasia. Mitoses must be unequivocal. There's no really strict cutoffs, but a single mitotic figure in a large specimen is insufficient to upgrade to a grade 3. Microvascular proliferation, there's going to be apparent multilayering of the endothelium or glomeruloid microvasculature. Necrosis can be any type, does not need to be pseudopalisading. And the order of appearance is going to be atypia, mites, increased cellularity, and necrosis and or microvascular proliferation. All right, moving on. So diffuse astrocytoma, WHO grade 2, also known as a diffuse astrocytoma, IDH mutant, is a diffusely infiltrating astrocytoma with a mutation in either the IDH1 or IDH2 gene in adults, with no CDK2N A or B homozygous deletions. Most commonly, diffuse astrocytoma WHO grade 2 is going to occur in young adults in their mid-30s, most commonly in the frontal lobes, but can get anywhere in the central nervous system. Common presentation for neuropathology in general is seizures, as you can see with this type of tumor. So a well-differentiated fibrillary astrocytes is what you're going to see. Cellularity is moderately increased with moderate nuclear atypia, which you can appreciate here, with often loose microcystic background. Mitotic activity is generally absent. A single mitotic figure in a large specimen is acceptable, but not a biopsy. So for molecular or IHC, you're going to have IDH1 or IDH2 mutations. The most common mutation, around 90%, is IDH1 R132H, which can detect with mutation-specific IHC. You can also have ATRX mutations or a loss of ATRX on IHC staining, as well as TP53 mutation with strong nuclear P53 IHC staining, and the Ki67 is usually less than 4%, and they're going to express GFAP. So a diffuse astrocytoma, WHO grade 2, is often going to have slow growth with survival of more than 5 years, and now even often more than 10 years, with intrinsic capacity for malignant progression to anaplastic astrocytoma and a GBM. For a gametophytic astrocytoma, this is a variant of IDH mutated astrocytoma with prominently gametophytic neoplastic astrocytes, more than 20%, and historically thought to progress faster, but may not be true. For pediatric diffuse astrocytoma, you're going to have the same histology, but they're much less common, and they are most common in the cerebrum, but also the thalamus. There's rarely progression. MIB and BRAF alterations can occur, and there's going to be absent IDH1 and 2 ATRX mutations. All right, next up, we've got anaplastic astrocytoma. So diffuse astrocytoma was WHO grade 2. Anaplastic astrocytoma is WHO grade 3. So this is going to be a diffusely infiltrating astrocytoma with focal or diffuse anaplasia, significant proliferative activity, and a mutation in either IDH1 or IDH2. And just like for grade 2, for grade 3, you have no CDKN2A or 2B homozygous deletions. These can arise from grade 2 diffuse astrocytomas, but most of the time there's no precursor lesion identified. Most commonly in the cerebrum, although they can get anywhere in the central nervous system of young adults, often in their 30s. And they have a similar appearance to diffuse astrocytoma, often with more nuclear atypia and higher cellularity. You often also have increased pleomorphism, coarse chromatin, prominent nucleoli, multinucleation, and atypical mites, all of which you can see in this image here. We've got a nice mite, we've got some prominent nucleoli that we can appreciate with some nuclear atypia as well. So for increased mitotic activity, you must evaluate in the context of the sample size. A single mitotic figure on a biopsy is enough. In resections, you need to see significant mitotic activity, often 2 or more. So by definition, no necrosis and no microvascular proliferation occur in the anaplastic astrocytomas. Otherwise, it would be a GBM. There is an intrinsic tendency to progress to GBM for a WHO grade 3 astrocytoma or anaplastic astrocytoma, and the historic survival is about 3 to 5 years, but is increasing or improving. So molecular or IHC, you're going to have IDH1 or IDH2 mutations, and the most common mutation is IDH1 R132H. I apologize. And you can detect with mutation-specific IHC. You can also have ATRX mutations, which lead to a loss of ATRX IHC staining, or TP53 mutation with strong nuclear P53 IHC staining with a Ki67, usually 5 to 10%, and they're going to express GFAP. All right, so next up we've got Glioblastoma, or a WHO grade 4. The old name was Glioblastoma multiforme, or GBM. This is a high-grade glioma with predominantly astrocytic differentiation with nuclear atypia, mitotic activity, and, importantly, also microvascular proliferation and/or necrosis, with often diffuse growth. This is the most common malignant primary brain tumor in adults, often diffusely infiltrates adjacent and distant brain structures. So on imaging, you're going to have irregularly shaped with ring-shaped enhancement around central dark necrosis, and can grow along the corpus callosum into the other hemisphere, giving that classic butterfly glioma appearance on imaging. And patients will often present with a seizure or neurological deficits. So there's 2 major molecular pathways with dramatically different prognoses. So you have IDH wild type, which is the primary pathway. Much more common, occurs in older patients with no precursor. You're going to have a TERT promoter mutation, rapid progression and death, often within 1 year. And then there's also IDH mutant, which is the second molecular pathway, which is less common. Younger patients with precursor astrocytomas who have a 9p, CDKN2A or 2B deletion. This is going to be a slower progression with prolonged survival up to several years. So the IDH wild type actually has a worse prognosis and a quicker progression, whereas the IDH mutant has prolonged survival and a better prognosis. To distinguish between the two, you can perform IHC for IDH1, R13-2H. But first, if it's positive, you have an IDH mutant, and if it's negative, you proceed to IDH1 and 2, sequencing to exclude other mutations. However, this may be unnecessary in older patients with classic histology. So continuing with glioblastoma, just to start working our way through the histology. So they can have a variable histology, hence multiforme or multiple forms. They are highly cellular with poorly differentiated, sometimes very pleomorphic tumor cells and brisk mitotic activity. There's either necrosis or microvascular proliferation, as we've discussed, which are both imaged right here. So this is this nice classic palisading necrosis of a glioblastoma, and then the microvascular proliferation in this bottom image. You can have glomeruloid tufts of multi-layered, mitotically active endothelium with smooth muscle and pericytes, often near necrosis, and you can often have regional heterogeneity. And tumor cells will often migrate or invade around existing structures and around neurons, which is known as satellitosis. So there's specific morphologic patterns of glioblastomas, including small cell glioblastoma, glioblastoma with a primitive neural component, gametocytic glioblastoma, lipidized glioblastoma, granular cell glioblastoma, and adenoid glioblastoma. For IHC, they're typically going to stain with GFAP, S100, OLIG2, and the Ki67 is typically about 15 to 20%, but can be much more. These can grow into multiple lobes or hemispheres, known as gliomatosis cerebri, and metastases are very uncommon. Again, the two molecular pathways are outlined here for a glioblastoma. So you have IDH wild type glioblastoma or IDH mutant. For wild type, it's going to be, a synonym would be primary glioblastoma with no precursor lesion. This is going to be over 90% of GBMs, commonly diagnosed later in life, so around 60 as compared to 45 for the IDH mutant glioblastoma. And then the mean length of clinical history and the survivability are both shorter for the wild type glioblastoma. Typically IDH mutant glioblastoma, interestingly, occur specifically in the frontal lobe, and there may be limited necrosis, unlike IDH wild type GBMs, which have extensive necrosis. And then clearly the molecular, by definition, IDH wild type, IDH mutant, are going to be different. So for IDH wild type GBMs, you have 70% of those have TERT promoter mutations with rare ATRX mutations, and about 35% have EGFR amplifications, 25% have P10 mutations. But for IDH mutant GBMs, they only about 25% of the time have TERT promoter mutations, and commonly 70% of the time have ATRX mutations and rarely have EGFR or P10 mutations. And then MGMT promoter methylation status predicts response to alkylating chemotherapy agents. So some of those variants that we mentioned. You can have an epithelioid glioblastoma, which is going to be a high-grade diffuse astrocytic tumor with a dominant population of closely packed epithelioid cells, which is what we see here, with some rhabdoid cells, mitotic activity, microvascular proliferation, and necrosis. And this is predominantly going to occur in young adults and children. For IHC and molecular, some of the same themes we've already discussed. You're going to have positive GFAP, S100, Vimentin, with frequent expression of the cytokeratins AE1, AE3, or EMA. And frequently, epithelioid glioblastoma are going to have BRAF V600E mutations and are going to be IDH wild type. So these are pretty aggressive with a short survival of about 6 months. Next up, we've got giant cell glioblastoma. So this is a rare variant of IDH wild type glioblastoma with bizarre multinucleated giant cells, often more circumscribed and often has a better prognosis with a high rate of TP53 mutations and rarely EGFR amplifications. And if you see this histologically, you would want to consider a PXA or a pleomorphic xanthoastrocytoma in a differential diagnosis, just because you have some of, well, it looks pleomorphic, and then you have some of that xanthomatous appearing cytoplasm as well. So PXA would definitely be something you'd want to rule out. So we got Gliosarcoma up next. So a Gliosarcoma is a variant of IDH wild type glioblastoma with biphasic growth displaying glial and mesenchymal differentiation. It's analogous to epithelial to mesenchymal transition in carcinomas. And there's going to be a sarcomatous component, which often has a spindle cell pattern with densely packed long bundles of spindle cells with abundant reticulin framework. Also, there's going to be mitoses, necrosis, and atypia. On IHC, the sarcomatous components often lack GFAP, and they can have heterologous differentiation. So gliosarcomas have a similar prognosis and clinical characteristics to IDH wild type glioblastoma.